Good evening, everyone. My name is Jennifer Bailey. I'm the Director of Physician Referrals Relations here at the Karmanos Cancer Institute. It is my pleasure to welcome you to our ongoing education series for oncology updates for medical professionals. Tonight we have a topic with both Dr. Brown and Dr. Simon speaking on the management of women at increased risk of breast cancer. It's my pleasure to welcome and introduce them both this evening. I have a couple of quick housekeeping items I'd like to cover prior to their introductions. First of all, we have no disclosures this evening. This meeting is being recorded and will also be upheld after the fact on our website for ongoing CME education units. And the education number will be provided through CME Tracker, and I'll be sending that out, if not later tonight, tomorrow morning, with the CME number and the tracker number. Included in this chat is the way that you go ahead and apply through CME Tracker if you've not actually done and created that account. And again, we want to take this time an opportunity to welcome you all here this evening. It's my pleasure to introduce both of our speakers here tonight. Dr. Eric Brown attended his undergraduate degree at University of Michigan and finished medical school at the UHS, the Chicago Medical School. Completed his general surgery residency at St. John Hospital in Detroit. And Dr. Brown is a breast surgeon and co-leader of the Karmanos Cancer Institute multidisciplinary breast team. In addition to all of that, he's a clinical assistant professor of surgery at Wayne State School of Medicine and also Oakland University, William Beaumont School of Medicine. Dr. Michael Simon attended the University of Illinois College of Medicine and completed his residency and fellowship at U of M in Ann Arbor. Dr. Simon is a medical oncologist and co-leader for the Karmanos Cancer Institute multidisciplinary breast team, and he is also the medical director for the Cancer Genetics Clinic at the KCI. His research interests include racial disparities in cancer genetics. So I want to welcome both of you for that. A couple of quick comments. Q&A is going to be available via chat. During this presentation, if you have any questions, feel free to enter your questions there. And also we'll be having about 10 to 15 minutes of Q&A after the presentation. So with that, I'd like to turn the evening over to Dr. Brown and start his presentation. Thank you so much.
Good evening, everyone, and welcome to our CME event. Today, we're going to be talking about breast cancer high risk and the need for a high-risk clinic. I'm Dr. Eric Brown, and along with my colleague, Dr. Michael Simon, we're going to talk about high risk as well as high-risk genetics. And hopefully we'll give you some good information that can help you in your practice, as well as give a little plug for what we are in the process of initiating, which is the development of a high-risk breast clinic. In 2019, almost 270,000 cases of invasive breast cancer were made, and about 63,000 cases of a non-invasive breast cancer called ductal carcinoma in situ. That same year, about 42,000 women died from breast cancer, making it the second leading cause of cancer death. As we know, about 1 in 8 women will develop breast cancer in her lifetime. In the McLaren system, we are very good at offering screening mammography. Even in the recent era of COVID, we still performed almost 100,000 mammograms in 2020. Screening mammography is an excellent place where we can identify women who are at high risk and maybe institute some type of intervention. Annually, almost 1 million breast biopsies are performed, of which about 10% come back with the diagnosis of atypical hyperplasia. There's about 87,000 women alive in the United States with a diagnosis of lobular carcinoma in situ. Both of these diagnoses are significant in elevating a woman's risk of developing invasive or non-invasive breast cancer in her lifetime. Clearly, we identify a lot of women who fall into this category. It's estimated that there's over 1 million carriers of a BRCA mutation. About 90% are asymptomatic and have not been identified. Clearly, this is a lack of identifying patients who clearly have a high risk of breast cancer. The increasing need for a high-risk program is vital to addressing some major concerns amongst women who are in a high-risk population. Many women are under-screened. Few women know their options, including taking medication to lower their risk. And very few women actually understand their risk and what does it mean. There are many risk assessment tools available to assess a woman's risk. And again, a great opportunity to utilize this technology is when women have their screening mammogram. Physical data like height and weight, ethnicity, their childbirth history, and of course, family history and history of prior biopsies are all very significant in determining a woman's risk for developing breast cancer. Most recently, the idea of breast density has come to the forefront of breast imaging. Breast density is a mammographic depiction of how much breast tissue versus how much fatty tissue is found in the breast on a mammogram. As the amount of breast tissue goes up, so too does the breast density. And as you can see in this diagram, the greater the density, as you can see BI-RADS A to BI-RADS D, the lifetime risk of developing breast cancer using a statistical model goes up. So breast density is a big influence on women's risk for breast cancer. Breast density is assessed mammographically, and again, no better time than at the time of screening mammography to identify these women. I mentioned previously the diagnosis of atypical ductal hyperplasia and its influence on breast cancer risk. And we can see by these two diagrams that women who have that diagnosis, typically made on a biopsy of the breast, will have an increased risk of developing breast cancer over time. That risk is cumulative over time and higher than women without that diagnosis. The more times or the more foci of atypical hyperplasia, the greater the risk of developing breast cancer. This diagnosis is established at biopsy, but more importantly, needs to be discussed and explained to women, as well as options given as to how to address. Similarly, lobular carcinoma in situ, which is not breast cancer but high risk, is another diagnosis made at biopsy that carries with it elevated risk and the need for high risk assessment. Over a 30-year time period, Memorial Sloan Kettering reports as high as a 26% increased risk of developing breast cancer in women with this diagnosis. In that same data set, we know that women with the diagnosis of lobular carcinoma in situ, as well as high risk breast density, that is BI-RADS C or D, also referred to as heterogeneous or extremely dense breast, have almost an 8% increase in developing breast cancer over that same time frame. So clearly, breast risk is complex and multifactorial. So when women are diagnosed with high risk, what can be done to address that risk? There are modifiable and non-modifiable actions. Obviously, issues such as alcohol use, smoking, weight gain, and the lack of physical activity are very modifiable actions that can address these women who are at high risk and are looking for methods that they can institute to lower their risk. And needless to say, this can be applicable even to women who are not at high risk. Obviously, some non-modifiable issues include having the diagnosis of lobular carcinoma in situ or atypical hyperplasia, as well as family history, because we all know we can't choose our family. Studies have shown that drinking more than 1 drink per day is associated with an increased risk of developing breast cancer. Similarly, there's an increased risk in women who are obese. And exercise has been shown to reduce the risk of breast cancer by as much as 30%. So here are easily modifiable actions that can be implemented in a high-risk program, taking the patient who is at high risk and giving her modifiable actions to address that risk. In the data from Memorial Sloan Kettering, you can see that a fair number of women in their cohort drank more than 1 drink per week. 38% were overweight or obese, and half the women admitted to not exercising. Clearly, improvements can be made in these modifiable actions. Aside from modifiable actions, we know that screening mammography is the best way to identify women who have early findings suggestive of cancer, leading to early diagnosis, leading to improved overall survival from breast cancer. In fact, we know when screening mammography became mandated, if you will, by many insurance companies, by many of the cancer societies in the early 1980s, the death rate from breast cancer began to decline. And this was basically due to early detection. So when you have somebody who's at high risk, what else can be done to address that risk? Well, certainly screening mammography remains the gold standard. Digital mammography with tomosynthesis or 3D mammography has become probably the most sought after type of mammogram in this day and age. It allows multiple pictures to be taken of the breast to allow for the identification of lesions that might be either too small or easily hidden within dense breast tissue. In addition, breast MRI or whole breast ultrasound has been shown to help identify women who have very early findings of malignancy before a malignancy becomes palpable. The success of a good screening program can be explained by the detection and surgical removal of breast cancer before it has had a chance to metastasize. High-risk women who are at greater risk of this happening certainly need to have more efficient and more frequent screening. Breast MRI is one of the more commonly implemented screening tools, in addition to mammography, used in women who are at high risk. There are multiple recommendations as to who should get a breast MRI, most notably those women who experience a lifetime risk of developing breast cancer of greater than 20%. And this number, greater than 20%, is calculated using the screening models that I had mentioned previously. We're very excited at Karmanos to introduce soft view 3D breast ultrasound tomography. This is, in essence, 3D breast ultrasound. It was recently FDA approved, and a clinical trial looking at the use of 3D tomography in high-risk women is soon to open. Literally, this technology allows ultrasound to look at the breast in much the same way as a 3D mammogram looks at the breast, layer by layer, rather than just the old form of mammography, which were essentially two views, one from the top and one from the side. In addition to screening and high-risk screening, there are interventions we refer to as chemoprevention, where we use medications to lower the risk of getting breast cancer. There have been multiple trials throughout the United States and Europe looking at the drug tamoxifen as a risk-reducing agent. Tamoxifen, many may know, is a treatment for breast cancer. More recently, studies looking at other anti-estrogen medications called aromatase inhibitors have also been performed with hopes of identifying methods that can reduce risk in high-risk women. A meta-analysis of all the trials looking at tamoxifen, or what's referred to as a SERM, and those using aromatase inhibitors, commonly referred to as an AI, have both shown a significant reduction in the risk of breast cancer in high-risk women who take these drugs on a daily basis. In fact, the reduction is almost 50% in both groups. Interestingly enough, however, despite this knowledge, very few women actually agree to take these medications. Looking back at the Memorial Sloan Kettering data, almost a quarter of the women refused to even start the medication for fear of side effects, or they weren't interested. Others deferred, and others actually started the medication and actually stopped. So in most high-risk programs, it's actually quite astonishing that barely 60% of women who start the treatment, which is a 5-year daily treatment, actually complete that treatment. So there are high-risk women who have an opportunity to reduce their risk, and because of medications and side effects of medications, actually decline. Another important role of a high-risk clinic is to perhaps educate and inform women as to the benefits of these medications and options in terms of dosing these medications. Well, what about surgery as a means of reducing risk? Well, we know that women who are at the highest risk of developing breast cancer in the future are women who carry a breast cancer gene, the BRCA1 or BRCA2. These genes carry with them approximately a 65% risk of developing breast cancer over that woman's lifetime, which is very significant. Certainly much higher than any non-BRCA mutation carrier would have. There are other relatively significant genes that are now tested in a genetic testing panel that carry lifetime risks of developing breast cancer, also in the neighborhood of 20 to 50%. So the most common patients that actually do decide on surgery rather than high-risk screening, rather than chemoprevention, are genetic carriers. We counsel women when they carry the gene for breast cancer that the risk of developing breast cancer can be significant, but that risk is actually over time rather than immediate. So, in other words, women who are 40 years old and carry a BRCA1 mutation have a risk of developing breast cancer of over 60%. The risk on the day that she finds out that she carries the gene is zero, assuming she doesn't have breast cancer on that day. By the time she's 85, that number will reach approximately 65. The curve, or the risk of developing breast cancer over time, goes up annually. Needless to say, with the lifetime risk that somebody who's 40 years old has over their lifetime is 65%, prophylactic surgery is a very, very common choice at addressing and all but eliminating that risk. As we look at the recommendation for prophylactic mastectomy, further emphasizing the need for a high-risk clinic is looking at recommendations for prophylactic mastectomy. BPM is bilateral prophylactic mastectomy in BRCA mutation carriers. And we see that between family medicine, internal medicine, OB, general surgery, or oncology, the recommendations for bilateral mastectomy varies greatly. So the need for somebody to clearly follow those patients, talk to those patients, counsel those patients is extremely, extremely important. Studies report a 90 to 100% reduction in the risk of breast cancer development following bilateral prophylactic mastectomy. But in the United States, about only 50% of patients who carry the mutation actually undergo the surgery. And in today's day and age, we are doing what's referred to as a nipple-sparing mastectomy. So from a cosmetic standpoint, patients look and feel very confident, very normal, and certainly very happy when their risk is reduced. So identifying patients at high risk and utilizing all of the technologies from screening to chemoprevention to surgery, these are all options that need to be discussed, and that conversation is best had by a professional trained in the high-risk breast patient. So the purpose of a high-risk clinic is to allow for testing and screening for high risk. And again, the best time to screen is at the time of mammography. You have a captive audience at that time. The technology that we're using is an application that's on an iPad that patients can fill out when they go for a screening mammogram. And within seconds, it'll calculate their risk of carrying a breast cancer gene, as well as their risk of developing breast cancer. And then when certain risks are reached, those patients can be navigated to the high-risk clinic. At the same time, that patient's risk can be relayed to the primary care physician, as well as to the patient, so that all are informed of that patient's risk and what the plan is. Within the software that we have is a very well orchestrated set of applications for genetic testing that are automatically filled out, letters that are sent to the patient indicating their risk, indicating the discussion that took place at the high-risk clinic, and indicating to them what their next steps would be. If authorizations are needed, for example, for a breast MRI, the software has the ability to create a letter with lifetime risk numbers automatically placed within the letter to help these studies get performed and authorized. So again, mammography saves lives. We know that to be the case. We're missing a lot of patients who are at high risk and don't know it. And we certainly want to provide patients with an opportunity to know that their risk is high. We want them to be informed of their options. And of equal importance, we want to make sure that their primary care doctor is aware that the patient not only has been identified as high risk, but navigated to the high risk clinic, and keep everybody in the loop, if you will, as to what are the next steps for that patient. Thank you very much for your attention. Appreciate everybody's time. I'm going to pass the mic over to my colleague, Dr. Simon, who's going to talk more about risk as well as genetics.
Good afternoon. My name is Michael Simon, and I'm going to be speaking on the incorporation of cancer genetics in a medical oncology practice. So the objectives of the talk are to speak about the scope of the problem in regards to cancer genetics, genetic counseling, and genetic testing. And also, even though this is a high-risk breast clinic talk, cancer genetics also applies to several other tumor types. I will focus on breast cancer, speak about breast cancer risk factors, focus on hereditary breast and ovarian cancer syndrome, and also speak about other hereditary syndromes. I'll be speaking about screening and management, and then a bit at the end on tumor genomic profiling. So to start with, as Dr. Brown exemplified in his talk, breast cancer is the #1 cause of cancer in women. The estimated lifetime risk of breast cancer is 1 in 8 or 12%. Hereditary cancer syndromes and genetic testing also incorporate the risk for other cancers. So just for your reference, the average lifetime risk of colorectal cancer is 1 in 11 or 6%, and the average lifetime risk of prostate cancer is 1 in 7 or 14%. And lastly, the average lifetime risk of ovarian cancer is 1 in 50 to 100 or 1 to 2%. It is important to mention racial disparities in any of our talks regarding a high-risk clinic. The point of this slide is that survival for all these sites overall, this is the 5-year relative survival for Black versus white individuals, is less. There's an absolute lower survival percentage of 6%. And then for breast cancer specifically, and this is data from 2009 through 2015, the absolute difference was 9%. And this exemplifies the importance of providing high-risk screening and, when applicable, genetic counseling and testing to all women at risk. According to the U.S. Preventative Services Task Force, there's a recommendation for genetic counseling and genetic testing for breast cancer-related cancer. Primary care clinicians should assess women and men, when applicable, who have a personal and or family history of breast, and men can get breast cancer, of course, ovarian, tubal, or peritoneal cancer, or ancestry associated with BRCA1 or 2 genetic variants, pathogenic variants or mutations. And this is recommended through a brief familial risk assessment tool. When results are positive, to refer to genetic counseling and indicated genetic testing. But this is not for all women or men without these characteristics. So the challenges to the field are exemplified in this article from 2015, which showed, based on a large national survey, that 20 to 30% of eligible patients, based on a personal history, that is a personal cancer history, only 20 to 30% discuss genetic testing with a clinician. The second point refers to individuals, women who are unaffected, that don't have cancer, but have a significant family history. And only less than 10% of these women reported discussing genetic testing with a provider. Issues faced by providers include infrequent experience regarding genetic counseling and testing, lack of updated knowledge, and lack of familiarity with advanced genetics services. So let's walk through a typical case. So in our office, we may see a 50-year-old woman, and that's exemplified by the arrow, as she is our proband. She has a sister with breast cancer diagnosed at 48. She's concerned about her family history of breast cancer. So the questions that we may try to address are, what is her own lifetime risk for breast cancer based on her sister's risk? What is the possibility that this is running in the family that is hereditary? And what can be done about prevention, both primary prevention, preventing a cancer, and secondary prevention, finding a cancer early, at an early stage, an early, more curable stage if we can. So in regards to breast cancer risk factors, I'd like to highlight the fact that BRCA1, BRCA1 and 2, or other genes have a very high and almost the highest risk associated with the highest risk of breast cancer. So the relative risk means that for women with a BRCA1 or 2 genetic variant, they have a 5-fold greater risk of breast cancer than women without that genetic variant. Breast density is also a risk that was, and this was also gone over in detail by Dr. Brown. And this slide shows by breast density by level, with level 4 being the highest dense and described as extremely dense. And this is seen by 10% of women, US women, and this is associated with a 4.64-fold increased risk of breast cancer. So we get additional history from our proband, and she is 50. Race is used in some of the models. Her age of first menses was 13. The age of the first live birth was 30. She has one first-degree relative with breast cancer shown by this small pedigree, and she had one biopsy which showed atypical ductal hyperplasia. These are all risk factors used in a model to estimate her lifetime risk for breast cancer. So if we then look at a model, this is called the Gale model. It was an early model used to assess 5-year and lifetime risk of breast cancer and to predict the effectiveness of chemo prevention medications. This model incorporates age and reproductive history as stated, the biopsy, and family history. What the model does not incorporate is a family history of cancers other than breast, or in second-degree relatives, such as in the paternal side. So it misses hereditary risk, unless it's coming from the maternal side, and it does not incorporate the age of diagnosis, which may be important. So her risk, according to the Gale model, is a 5-year risk of 4.5%. The average risk for a 60-year-old is 1.67%. So she's considered at increased risk, and she would be eligible for chemo prevention with tamoxifen or raloxifene. Her estimated lifetime risk is 35%, and I contrast that with an average risk for women that I showed you earlier, which was 12%. But as I just mentioned, the Gale model can underestimate hereditary risk, and as you can see in this pedigree, now that there's a very significant history of early onset breast cancer and ovarian cancer on the father's side of the family, which would be missed by the Gale model. So we can also look at class tables, and this was developed from a large mammography study, and or actually this was developed from a study called the Cancer and Reproductive Hormone Study of 5,000 women with breast cancer compared to 5,000 age-matched controls. And this data looks at the age of the family member. So if your mother, sister, or on both the maternal and paternal side, if your paternal aunt is at a young age, then your risk is higher. So based on the class table, this particular patient's risk is 13.2%. Her sister was 48, not particularly young. If the risk is greater than 20%, we recommend mammography alternating with breast MRI. Dr. Brown went extensively into the Tyler-Cusick model. I want to emphasize that this model also includes, in addition, breast density to more accurately assess breast cancer risk. And this is the model that we're using for our high-risk clinic. Some more details on our family. We got a 3-generation pedigree, which is what we do in the genetic counseling clinic. Turns out that her paternal aunt had stomach cancer. Her grandfather had cancer of unknown primary site. Her sister was 49. And when we get and confirm more information, it turns out that the grandfather had male breast cancer and he was of Ashkenazi or European Jewish ancestry. The aunt had ovarian cancer and not stomach cancer. And so now this is a very high-risk family with two major red flags, three red flags: breast cancer less than 50, ovarian cancer, and male breast cancer. So this person is referred for genetic counseling. So what happens in the genetic counseling visit? Genetic counseling is the process of helping people understand and adapt to the medical, psychological, and familial implications of the genetic contribution to disease. So a genetic counselor will collect personal and family medical history, genetic test results, family cancer history. The genetic counselor will educate our clients on inheritance, on genetic testing, management, prevention, resources, and research. Counseling is also used to help people make informed choices. Not everyone necessarily understands the implications of genetic testing for themselves or for their family. This is our group. Actually, we have now two other counselors, but genetic counselor team includes physicians. This is myself, oncologists. There is genetic counseling and cardiology, of course, prenatal testing, neurology, etc. Consultants, as consultants are working side by side. We also work with nurses, social workers, dietitians, pharmacists, medical systems. Many of our patients, would benefit from psychological counseling if the issues are significant for them. So what are clinical features of hereditary disease? One red flag is 3 or more family members with a cancer associated with hereditary disease, either hereditary breast and ovarian cancer syndrome, HBOC. Here in this example, we talk about Lynch syndrome. So 3 family members with colon cancer, or 3 family members with breast ovarian cancer, or one person with 2 or more cancers, maybe a female with colon and endometrial, or maybe breast cancer or breast and ovarian cancer. In regards to hereditary colon cancer, for hereditary polyposis syndromes, we look at 10 or more polyps in the individual. We also look at age of diagnosis. And young age is considered to be less than 50 at diagnosis. And here are some examples of cancers we're concerned about: age, breast, colorectal, and uterine. Rare cancers. Male breast cancer, there's a lifetime risk of 0.1% for men, so that's relatively rare. Ovarian cancer is relatively rare with a risk of 1 to 2%. And ancestry, people of Ashkenazi or European Jewish ancestry have a somewhat higher risk for hereditary breast and ovarian cancer syndrome due to 3 founder mutations. So how much of cancer is hereditary? For breast, it's predicted to be 5 to 10%, ovarian somewhat higher at 10 to 25%, uterine about 5%, and the rest is sporadic, perhaps lifestyle, different exposures, or unknown, or perhaps there's other hereditary risks that we don't know about. In regards to breast cancer, about half is due to a variant, cancer-causing variant in BRCA1 or 2. There's additional genes in 12 to 30%, and then unknown in this section of about 25%. So the underlying principle of cancer genetics is defective repair of DNA damage. That's defective repair of double-strand breaks that results in genomic instability and cancer risk. There's other causes, of course, of cancer that could impair DNA damage, such as radiation, chemotherapy. What we're focusing on here are germline mutations that's inherited and transmitted in the family. So we talk about both germline mutations and somatic mutations. So germline mutations are inherited from a parent, and then the acquisition of a second mutation due to DNA damage leads to loss of function and increased risk. Somatic mutations are derived from testing tumors, and it's thought that an individual may have a somatic mutation if they smoke for a long period of time, and perhaps there's a second insult, either diet or alcohol or some other lifestyle factor, and they acquire a second mutation and develop a cancer. Blood, sputum, or skin biopsy is used for germline testing. Tumor testing can provide important information for treatment of tumors and could also potentially provide information for germline testing, which I'll get into later. So in tumor cells with defective repair of double-strand breaks, homologous recombination deficiency, DNA repair is inhibited, resulting in chromosomal instability, genomic instability, leading to cancer risk. A purpose of the slide is to show that in addition to BRCA1 and 2, there are a complex of other genes that assist in this double-strand repair process and are now part of our panels for genetic testing, and some few examples, RAD51, ATM, and ATR, but there's many more. So what are some of the clinical features of hereditary breast and ovarian cancer syndrome? Vastly increased risk of all these cancers listed as shown by the pink bars compared to the gray bars, which are population risk. So ovarian cancer population 1 to 2%, up to 11 to 40%. Breast cancer dramatically up to 45 to 87%. A pretty wide range in the estimates based on different studies: male breast cancer, prostate cancer, pancreatic cancer. So of course, hereditary cancer affects both men and women, and melanoma for BRCA1 and 2. So testing for BRCA mutations has many potential implications. First of all, if an individual has breast cancer, perhaps metastatic breast cancer, knowing that they have hereditary cancer could imply that they may respond better or worse to different treatments, better response to platinum-based chemotherapy, better response to PARP inhibitors, which is a new treatment for hereditary BRCA1 and 2 type cancers, and help inform the patient's care plan. Also provides prognostic information. This is maybe for individuals or women without cancer. We recommend risk-reducing surgery to prevent future cancers, or perhaps chemo prevention, and also provides families the opportunity to take preventative measures to avoid future cancer risk. And this is what we call cascade testing. So genetic test results can be difficult to interpret. So as in any result, we either have a true positive, that is, we found a pathogenic variant, deleterious mutation identified, leading to increased cancer risk, a true negative, there's no variant, or something that's indeterminate or uninformative, and those are called variants of uncertain significance. So I'd like to use the example that each gene is like a book, and then of course genetic testing is like a spell check, or making sure that there's not extra letters or missing letters, deletions, or rearrangements of words or pages. So for a simple example, if the word's supposed to spell theater, T-H-E-A-T-E-R, and it spells correctly, and all the words spelled correctly, then the results are negative. If the T is substituted for a C and it spells cheater, of course, a vastly different word, and this could be a cancer-causing variant, positive result. What if theater is spelled just slightly different as they spell in Great Britain? We may not know if this version of theater is associated with increased risk of cancer, and we would tell our patient, you have an increased risk of cancer. We don't know the exact risk, but something that will be reported on in the future once the lab reclassifies it. The purpose of this slide, basically the point is all patients with ovarian cancer or family history of ovarian cancer are eligible for genetic testing. It turns out that family history status doesn't matter. Up to 40% of people, women in this study, had no relevant family history, but they still had a BRCA1 or 2 variant, pathogenic variant. And this has to do with age in ovarian cancer. 71% of these women were older than 50. And I mentioned earlier that less than 50 is a criteria, but for ovarian cancer, age doesn't matter. 71% still had a pathogenic variant. What about breast cancer? We've talked about this extensively, 1 in 8 in the population. The problem is that there's an approximate 27% 5-year survival rate for metastatic breast cancer. This may be changing over time with better treatments, but it's incumbent upon us to identify individuals at increased risk so we could find them at an earlier stage and prevent metastatic disease. So the NCCN guidelines for germline genetic testing change over time. Some rough guidelines, anybody with breast cancer at 45 or younger, then various combinations of family history. Triple negative breast cancer at any age is a criteria now, not just at less than or equal to 60, or a combination, a woman with breast cancer and she has a family member with breast cancer less than 50. any family history of pancreatic cancer in a first or second degree relative, metastatic prostate cancer in the family, male breast cancer in the family or individual, of course, as well as stage 4 breast cancer, to consider the possibility of PARP inhibitors. So the scope of who to test is really widening all the time. So back to my family history. The grandfather had male breast cancer. The sister was tested. She's the most likely to have a variant, comparing her to her unaffected sister. So we start with the affected sister, and she had one of the BRCA1 founder mutations. So now our proband has a 50% risk of having that mutation as well, given the autosomal dominant inheritance. What do? If we find a positive result we identify at-risk adult relatives and offer genetic counseling and testing. We recommend increased surveillance, chemo prevention, and prophylactic surgery. So specifically, the surveillance encompasses MRI alternating with mammography starting at the age of 30. We only do annual MRI from 25 to 30. MRI and mammogram every 6 months after 30. We consider prophylactic bilateral mastectomy as an option. We discuss that with our patients, but we don't say that they have to have it. CA-125 and transvaginal ultrasound through childbearing years, semi-annually, every 6 months. Bilateral salpingo-oophorectomy for BRCA1 carriers between 35 and 40, and for BRCA2 carriers between 40 and 45. What about BRCA1 and 2 negative? If there's a known variant in the family, and we know that our individual, let's say our sister in this case, did not have it, our original proband, then we would say, well, she still has the risk of sporadic cancer. She should get screened annually starting at the age of 40. We encourage adherence to population screening guidelines. If we don't know of what's going on in the family, then we may emphasize risk of unidentified familial mutation. And let's say her sister was diagnosed at 40, we would probably start screening 10 years before 40 or at age 30. It's also possible to have an uninformative result, a variant of uncertain significance. If it's a highly significant family history, if this individual had a variant of uncertain significance, I would start screening this person at a young age. Her mother had breast cancer at 45. I would screen her at least by 35. So clinical management of patients with uncertain variants, we explain that cancer risk is not yet known. The lab eventually reclassifies the risk. Most of these uncertain variants turn out to be benign, about 90%, and we do individualized risk management. The limitations of traditional genetic testing is that we were sequencing, Sanger sequencing of 1 or 2 genes. It was unable to detect copy number changes of complete exons, and it was costly. And we just did single gene or disease panels. Not every person with a mutation is picked up by testing. So now we are doing next generation sequencing, ability to process millions of sequence reads simultaneously, generates large amount of data. And this is the old-fashioned test, and the result is negative. Consider other testing. Usually insurance or patients did not want to proceed with multiple testing, but now we're sending out multiple gene panels. Actually, in our clinic, we're sending out 96 gene panels. So less likely to miss something. So these are some of the other genes that we test for: CHEK2, HEM, PALB2, all associated with breast cancer risk. RAD genes are associated with ovarian as well. CHEK2 associated with colon cancer. And we could predict the risk of breast and other cancers using this expanded panel, again, 96 genes. So lifetime risk of breast for BRCA1 and 2 is listed, and for Cowden syndrome, P10 is not as high. CDH1 is interesting, and that's associated with hereditary lobular cancer, lobular breast, and hereditary stomach or gastric cancer. So benefits of multiplex genetic testing: identify more people at risk. We could do cascade testing of family members. It has therapeutic implications. And sometimes we find something that we had no idea we would find. I've had patients with CDH or CDH1 hereditary gastric cancer, and then we can identify somebody at greater risk for stomach cancer, which they may not know about. A risk, sometimes people are more worried if they have 1 or more VUS. However, these are reclassified eventually. Sometimes there's a surprise result, and I always explain that we're testing for more than breast cancer, especially if there's a family history of stomach cancer. I warn people about the possibility of finding hereditary stomach cancer. There's sometimes uncertain recommendations because we don't have the knowledge yet for all the results, or sometimes there's inconsistent results across labs. I want to mention now at the end, the last slide or two, tumor genomic profiling. This is being done to determine better treatment options for patients with metastatic disease. It's really taken off in breast cancer. We're using molecular intelligence, or CARIS, at our center. Use of an archival paraffin-embedded tissue as a source of DNA. There's a large number of actionable mutations. It's possible that we would identify hereditary risk, or the possibility of hereditary risk. Overall results of clinical trials show higher response rates when we do tumor genomic profiling and increased progression-free survival. And I think this is really, moving forward in oncology. So clinical considerations, we need to tell our patients when they have tumor genomic profiling that we might identify a gene that's associated with hereditary risk. So the fact is, it's not just for treatment of the tumor, but there could be some hereditary component identified. So the question is, can we determine whether the variant identified by tumor genomic profiling is associated with increased cancer risk? Yes, if we get a blood sample or sputum sample in addition. Maybe, the lab sequences the tumor, and sometimes they find variants that they say this really may be hereditary, especially BRCA1 and 2. If we find BRCA1 and 2 in the tumor, we need to do blood sampling. So do not consider it as diagnostic unless clinically confirmed by a blood sample. Okay, in my last slide, according to the U.S. Preventive Services Task Force, risk assessment, genetic counseling, genetic testing for breast cancer-related cancer is recommended. It's recommended to identify people at risk, to provide this information, to test, and to provide, of course, informed consent, and patients understand why they're getting testing, and we hope that will result in lower cancer mortality rates. Thank you very much for your time.
Thank you both for the wonderful presentations. I want to take a few minutes to open up the forum, give us just a moment to technically get settled and to see if there are any questions for our speakers. Are we able to verbally ask questions, Tim?
Yes, if someone wants to raise their hand.
And I could, I don't know if Dr. Brown made it on, I don't see him right now, but I could address the question. I think there's a question about insurance and BRC and genetic testing. We always check insurance coverage at the time of ordering genetic testing, and our patients get contacted actually by many of the labs. They will be contacted if the cost is over $100. If our patients meet indications for testing, it's generally covered by insurance. My understanding, and of course we don't understand everything about insurance, my understanding is that the top cost for the panel genetic testing that we do is $250. But frequently, again, it's covered. So I know there was one question that was out there. I could see if something comes from the audience. Let's see. And maybe while people are formulating their questions, I'll try to address the other question having to do with breast cancer prevention. Of course, as we both said, breast cancer is the #1 cause of cancer in women. 1 in 8 lifetime risk. It's important to try to prevent breast cancer. I spoke mostly about identifying people, women or men, at extremely high risk of cancer, so that we could potentially do something to prevent breast cancer. Of course, the majority of breast cancer is not due to hereditary disease, that 1 in 8. And so we're talking about a high-risk program so that we could identify individuals at higher risk or an increased risk. We save the high risk terminology for women that have hereditary breast and ovarian cancer syndrome, but increased risk. So if there's increased risk, we sometimes do additional imaging. We're all very excited about the soft view that's been approved, and we have soft view downtown Detroit, and I think it hopefully will be an excellent addition to mammography for identifying early cancer. So that's secondary prevention, finding a cancer early. What about primary prevention? I can say that when I prescribe tamoxifen or any of the hormone blocking treatments for prevention, I'm not going to make people feel better necessarily. There are some side effects with it. Perhaps our patients can feel better if they are relieved that they're doing something to lower the risk. I think there's also a lot of lifestyle risk factors. And perhaps, we all know about tobacco and cancer, and there's some studies suggesting there's a link between tobacco and some breast cancer, but alcohol is a risk factor. Maybe on the individual level, it's not as strong, but on a population level, I do think it accounts for some breast cancer. So we suggest not to drink more than on average 1 drink a day, 7 a week, fewer than 7 a week. Maybe 2 glasses of wine on a Saturday night is okay, but not 2 glasses every day or 1+ glass every day. We think lifestyle, diet, exercise, there's a number of studies looking at obesity and breast cancer. We participated in a weight loss study in our breast cancer patients in the past, showing a lower risk of recurrence for women that lost weight. So I think really a good diet, a healthier diet, not the fast food American diet, but more fruits and vegetables, up to 5 to 8 servings, less red meat. It prevents cancer, likely. It prevents heart disease. And probably if we eat fewer cows, we'll save the planet. So that's my public health and environmental message. I might add, I'm not a fan of the chicken farms either, but I think red meat, in terms of cancer risk, it's really red meats. Any other questions?
So Tim was posting in the chat, if you want to ask a live question, please use the raised hand function. It's at the bottom, typically it would be the bottom of your Zoom screen, and we can unmute you and you're able to speak and share your camera. Do we have any questions for the group?
Can I add something else about taking pills, tamoxifen for prevention? Certainly, there may be side effects, and a lot of our patients tolerate it, but one can always try it, and it can be stopped. I think we all have a feeling if we start a medicine, it's dangerous to stop it. I think for either tamoxifen or raloxifene for chemo prevention, if you don't tolerate it, we just stop it, and it's okay.
That's a good point. Well, with that, it's 5:58. I don't see anyone raise their hands unless I'm missing something here. So I want to thank everybody for their time and for joining us this evening. And again, I'll be sending out an email communication with the CME number that's attached to this once I get it back from corporate. And again, thank you all so much for your time, and Dr. Simon and Dr. Brown for your expertise and your time this evening. Thank you all for joining us.
Thank you.